Good afternoon. My name is Andrea Kovac, and I am an attorney at the Sargent Shriver National Center on Poverty Law. Thank you for attending today's webinar. In collaboration with Health and Disability Advocates, this is the second in a series of Illinois Health Matters webinars to be hosted by the Shriver Center. Each webinar will focus on specific populations and will feature experts sharing their advice about advocacy to win the best possible Affordable Care Act implementation in Illinois. Today's webinar focuses on the effect of the Affordable Care Act on people with mental health issues and how the implementation choices being made now by Illinois policymakers may affect this population's access to affordable, comprehensive health insurance. After a few housekeeping matters, we will hear first from John Bowman, President of the Shriver Center, who will provide an introduction to this topic. Next, we will hear from Stephanie Altman, Programs and Policy Director of Health and Disability Advocates. Elizabeth Houston was not able to be here today. Instead, after Stephanie, we will hear from Alexander Brown, who is the Clinical Director at Metropolitan Family Services. Then we will open up for questions. If you encounter any technical difficulties, please contact Rachel Gilau at povertylaw.org or 312-368-1154. We would like this webinar to be interactive, and the presenters welcome your questions. Please keep in mind that we will answer your questions at the end. Please use the questions feature on your control panel to submit your questions. After the webinar, you will receive an email with a link to the webinar resource page where you can find the presentations and other resources. And now, without further ado, here is John Bowman.
Thank you, Andrea. Hello, everyone, and welcome to the second in our series of webinars about the impact of the Affordable Care Act on various populations. Today, as Andrea mentioned, our focus is on mental health issues. We know that a large percentage of the population suffers from mental health conditions to one degree or another. They can interfere with employability and productivity and school performance. They can exacerbate the effects of treatment, or treatment of physical health conditions, or interfere with patient compliance with treatment of conditions. For example, we know that older adults with untreated depression are more likely to experience physical trauma such as falls and broken bones, or to fail to take their medicine for other impairments. Yet, the diagnosis and treatment of mental health conditions has been hampered by difficulties with insurance. While Medicaid covers most of this, non-parenting and non-elderly adults can have great difficulty becoming eligible for Medicaid, especially if a significant part of their inability to work is caused by mental health issues. In the private insurance arena, some policies do not cover mental health issues at all, some charge high copays, and many policies are subject to artificial limits on the amount and scope of covered services. For everyone, even if they have insurance coverage, the mental health system is plagued by a shortage of providers. Today, to help us understand what the Affordable Care Act says about these issues and what choices it presents to Illinois for how it will implement reform in the context of mental health, we have two top experts in Stephanie Altman and Dr. Alexander Brown. Stephanie will talk about the coverage expansions and implementation choices in the Affordable Care Act. These changes apply to everybody, but Stephanie will talk about the particular ways they apply to mental health issues. She will have some advice about issues to watch as Illinois develops its implementation strategies. Dr. Brown will talk about some of the more specialized issues that apply to the mental health field, such as mental health parity. Stephanie, take it away.
Thank you. Welcome to the webinar, and the first thing I'm going to do is talk about the overall key components in the Affordable Care Act. There is a provision for individual responsibility, and this is known as the individual mandate. This is the provision that you may hear about the most because it's in the newspaper and has been very much a part of the controversy over the Affordable Care Act. What this provision does is says that after January 1st, 2014, most people will be required by law to purchase health insurance. There are provisions to help people who do not have enough income to purchase health insurance to be able to purchase it. There are also provisions for people to be eligible for public health insurance, normally Medicaid, but sometimes Medicare, and that is what the individual mandate requires. There's also corollary responsibility for employers to provide health insurance. Large employers, which are generally employers with 50 or more employees, 85% of them now provide health insurance to their employees. The other 15% will now be required to grant health insurance to their employees. If they do not give health insurance to their employees or make an offer of health insurance, and their employees are low income enough to be able to get a subsidy to buy insurance on their own, the employer will have to pay a penalty. That ensures employer responsibility in health insurance to provide a counterpart to the individual responsibility. The Affordable Care Act also creates state-based health care exchanges through which individuals and small businesses, generally under 100 employees, but each state will have some decision-making in how many employees will be involved, can purchase coverage. These exchanges will be a shopping market for health insurance. They will work on a web-based system that will be backed up by a public-private partnership, and each state will have some decisions to make in how they set up this exchange. Premium and cost sharing will be subsidized for families and individuals who have low income. Small businesses will also be able to purchase qualified health plans for their employees through the exchanges. And we'll talk later about what Illinois is doing to set up their own healthcare exchange. The Affordable Care Act will also provide the largest expansion of Medicaid to childless adults. It will open up health insurance to people who have never been able to receive Medicaid in the past. These are primarily either adults without children or adults who have children who are over age 19, are no longer dependent children. It also has many significant private insurance changes, such as an expansion of coverage to dependent children up to age 26, and other reforms that allow insurance to be more affordable and more available to individuals and families. The most notable change after January 1st, 2014 is that insurance coverage will no longer be based on health status. There will not be a ban or change on insurance if you have a pre-existing condition. The insurance that you buy will be dependent on your age and where you live only. In Illinois right now, there are several Medicaid programs that cover low-income individuals. It is based on the category that you fit into. Children are in one category, pregnant women and parents in another category, and people with disabilities in a third. All Kids is the name of the Illinois program for children. It contains Medicaid as well as a higher income program for coverage of children. Family Care is the name in Illinois for parent coverage under Medicaid. Moms and Babies is the name of the program in Illinois, the Medicaid program for pregnant women and children. And AABD, Aid to Aged, Blind, and Disabled, is the name in Illinois for our Medicaid program for over age 65 and for people with disabilities. We also in Illinois have some Medicaid programs that cover fewer people. The General Assistance Medical Program is a limited program that covers a limited amount of benefits for some adults with significant medical conditions who do not meet one of the first categories. One of the most important requirements in receiving Medicaid today in 2011, if you are not a parent, a child, or a pregnant woman, is that you meet a very specific disability determination. You have to prove that you are disabled according to the Social Security Administration's rules and regulations. Normally that is done by applying for Social Security benefits like SSI, Supplemental Security Income, or SSDI, Social Security Disability Insurance. This is the key problem in trying to get people who have mental health issues to be found eligible under Medicaid. They must meet this disability determination unless they fit into some other category, such as being a pregnant woman or a parent. We also have other programs, specific programs for workers with disabilities, and specific help for people in the home and community who would like to remain in the community and not be served in an institutional setting. So before 2014, I'm still talking about today, you must meet a Social Security definition of disability if you don't fit into one of the automatic categories for Medicaid. This is without regard to your income or your assets or your citizenship status. You first have to be in the type of category that can get Medicaid before we even get to looking at your income or your assets. So unless you meet the Social Security definition of disability or fit within one of the pregnant, parenting, or children categories, you have to apply separately and be determined disabled in order to receive it. With a mental health diagnosis, you have to have very specific evidence of treatment, and you have to have very specific clinical evidence of diagnosis, and you have to meet very difficult definitions of disability. And this is a major barrier to people with mental illness getting Medicaid today. In January 1st, 2014, that will change completely because categorical eligibility for Medicaid based on disability will be largely removed. In 2014, anyone with income up to 138% of the federal poverty level. In the law, it says 133%, but there's an automatic 5% deduction. So practically anyone up to 138% of the federal poverty level will be eligible for Medicaid, regardless of whether they have a disability determination. This is estimated to be over 700,000 people in Illinois who at this point may have a mental health diagnosis, and this amount is approximately $11,000 per year per person. So that is the limit by which somebody under that income level will now be eligible for Medicaid in 2014. It's commonly referred to as the new adult group for Medicaid, and there is no need to meet the disability determination. You must be under age 65 and not in Medicare. There is no asset test for the program, so it does not matter if you have money in savings or own property. And there is a new income test that's a little different from the current Medicaid methodology in order to determine whether you're eligible. Importantly, the federal government pays for a much greater percentage of this expansion. Currently, people on Medicaid are reimbursed to their providers by the state of Illinois, and the state of Illinois then receives 50% in general, for some populations higher, back for every reimbursement dollar that they spend from the federal government. For the new adult group, in the beginning, the federal government will be paying 100% of the cost of caring for the people in the new adult group, and that will go down over a period of years to 90%, which is still a very, very high rate of coverage. I'm now going to turn it over to Dr. Brown, who is going to talk about once people actually get this Medicaid card, what kind of services will they be able to get covered under Medicaid?
Thank you very much. You can think of essential benefits as the minimum or floor of what will need to be covered and provided. Insurers always have the option to go beyond the minimum and provide additional or expanded benefits. Essential benefits are required of all the plans that will be sold through the exchanges, as well as Medicaid expansion plans. For example, Illinois' current coordinated care pilot, which has moved thousands of people with mental illness from Medicaid to Aetna and Care plans, will, by 2014, have to provide the essential benefits. As we've already seen with the pilot, it's a mixed experience for many people with mental illness because the Aetna and Care formularies are different and have in some cases required people to switch from medications that they've been on with success for many years. Other problems have been with being unable to get enough physicians and hospitals to sign up for the plan. Many activists are concerned that over time, these and other insurance companies will try to limit the services provided to people with mental illnesses, although the essential benefits requirements should help prevent this. The federal government will determine the details and definitions of what exactly need to be covered and provided under each essential benefit category, and the categories include emergency services, hospitalization, maternity newborn care, several others, including mental health and substance abuse services. But today, we don't know exactly what is going to be in each of those categories. The government is going to look at what the typical employers are covering in the plans that they're offering employees, and the government will make adjustments in states that have specific mandates for various coverage and services. These state mandates are expected to result in additional benefits and services being provided in some states in comparison to others. Therefore, the essential benefits floor will be somewhat higher in some states than others because some states require insurers to provide certain coverage and services that go beyond what the federal government is likely to deem as an essential benefit. The federal government has committed that coverage will be balanced and not unduly weighted towards any one of the categories or another. It's also committed that coverage and services will in no way discriminate against people because of the disability they may have, and will take into account the needs of diverse segments of the population, including persons with disabilities. And that's a great benefit to people with mental illness. Mental health parity laws were designed to correct the frequent imbalances in mental health and substance abuse coverage in comparison to coverage for other illness. In the past, it was not uncommon to have one co-payment or deductible for physical illness and other higher ones for mental illness and substance abuse. Limitations of coverage were also common, with mental illness and substance abuse services being far less available than for physical illnesses. The Wellstone and Dominici Mental Health Parity and Addiction Equity Act of 2010 addressed many of these inequities by requiring that if an insurance plan covers mental health or substance abuse disorders, that the coverage must be equivalent to the coverage for other conditions. Notably, the law does not require insurers to provide mental health or substance abuse treatment, but if they do, it has to be at that equivalent level. Illinois has codified and further expanded this law. Some people are concerned that the parity laws would result in more insurers not providing coverage at all for mental health or substance abuse treatment, but so far that hasn't been the case. It's still a concern moving forward. And now I'll move it back to Stephanie.
One of the provisions in the Affordable Care Act that doesn't deal with necessarily eligibility, enrollment, or coverage is the provision around coordinated care, and that deals more with the delivery system, so how people get their care. As Alex mentioned, the state of Illinois has been moving more towards coordinating care for Medicaid recipients, and the Affordable Care Act provides states with new opportunities to do so. One of those opportunities is known as the health home option. It is similar to other coordinated care arrangements that have existed for Medicaid recipients and for insured people. It's similar to a health maintenance organization, but it actually is named health home on purpose because it refers to the home of medical care being located in a place that could be a behavioral health center instead of a primary care center. So for instance, a mental health center could be the health home for a primary care arrangement if the health home also could continue to provide services for specialty care, primary care, hospital care, and behavioral health. Behavioral health includes mental health coverage as well as substance abuse coverage. States can get extra federal funding to pay for case management in order to coordinate these services, especially for populations with severe mental illness. The health home option specifically lists severe mental illness as a focus and targeted population for health homes, and Illinois and the Illinois Department of Mental Health and the Illinois Department of Health and Family Services, the Medicaid agency, are considering asking the federal government for permission to establish one or more health homes which would coordinate care for people with severe mental illness through either a behavioral health center or a medical center. This is a new option under the Affordable Care Act and will provide 90% federal match, so it's 90% for every dollar, 90 cents on every dollar for the case management and social work services. The coordinated care models that are being piloted in Illinois right now include the integrated care pilot that Dr. Brown referred to with Aetna and Illini Care. This pilot includes 40,000 people at full maximum coverage in Cook and the Collier counties, but it excludes people in the city of Chicago. So people with an address that has a 6060 zip code are excluded from the pilot at this point. It includes people with disabilities who are on Medicaid, so they're on the AABD program that we mentioned, the Aid to Aged, Blind, and Disabled program, and they live in one of the covered areas. They will be enrolled into the integrated care pilot program. They have a choice of either Aetna or Illini Care. There are provisions for changing from one system to another if the physicians that or the care that they're receiving is not to their satisfaction. Advocates are currently working with the contractors, as Dr. Brown mentioned, in order to prevent disruptions in care. There are the issues, as mentioned before, with some of the networks, but each Aetna and Illini Care, both companies, are continuing to enroll providers in hospitals every week. And advocates are meeting with the community liaisons of both companies to deal with any individual cases that have problems in terms of coordinated care. There are, importantly, exceptions available to each system, Illini Care and Aetna, to be able to obtain a single case agreement, which is a special exception to continue to see the provider that you're seeing now in order that care would not be disrupted until that provider either joins the network that you're on or you find a provider that's satisfactory to you. Illinois is also considering other coordinated care models. Legislation passed in December 2010, which requires that 50% of all Medicaid enrollees be in a coordinated care arrangement by 2013. Healthcare and Family Services, the Medicaid agency, importantly has said that this does not mean that 50% of all Medicaid enrollees must be in a health maintenance organization. It does mean that they need to be in some coordinated care organization or arrangement. Other models that are being considered include HMO populations and other kinds of risk-based coordinated care, such as the health homes we already mentioned, primary care case management, such as the program Illinois Health Connect that children are in right now in Illinois, and not-for-profit managed care community networks, such as the Family Health Network. Medicaid agency has said that one size does not have to fit all. One thing I wanted to mention, there's a typo in the first bullet point of this slide. I apologize. The legislation actually required that 50% of all Medicaid enrollees be in managed care by 2015, not 2013. There are concerns certainly out there and issues that we want to watch for in care coordination and in the integrated care program, especially for people with mental health, as Dr. Brown mentioned. We want to make sure that we hear from the community, from providers, and from clients as to what their experiences are in the program as this is rolling out, because this will be the model that Illinois will look to see what works or doesn't work in the future. And for people with mental health issues, staying with their current medications, even if the medications that are on a certain formulary, that's a list of medications that are generally covered by a certain company, may not work for them. A generic may not work for them. A specific type of medication might be required. They also may already have a current care arrangement that we would not want to be disrupted. So advocates are working with individuals to work through those individual issues and also with the companies. Illinois is also planning on a larger level to implement healthcare reform, not just through coordinated care, not just through Medicaid enrollment, but through setting up a healthcare exchange. Each state that is in the process of setting up a healthcare exchange, which is mandated to be set up under the Affordable Care Act, can now apply for grants from the federal government to help them do this. Illinois has received 2 grants, recently $5 million, to start the process of setting up a healthcare exchange, which needs to be operational. Actually, it has to be approved by 2013 and operational by 2014, so that small businesses and individuals will be able to purchase insurance. The Illinois legislature passed Senate Bill 1555, and it was signed into law by the governor in August. It creates a legislative study committee, which is looking at how to recommend to the legislature the design of the Illinois Healthcare Exchange. There have been sessions and hearings around the state in the last 2 months, and their recommendations, the Legislative Study Committee recommendations to the legislature, are due by September 30th, and that report will concern issues such as where the healthcare exchange is located. Is it going to be located in a current state agency? Is it going to be in a new quasi-state agency? What will be the governance structure of the healthcare exchange? Will that be governed by a governing board? Who will be the membership on the governing board? Issues such as conflicts of interest on the governing board, and how much coordination with the Medicaid agency will the healthcare exchange be required to facilitate. Advocates are coordinated in many activities to implement healthcare reform, including all of the issues that we've talked before. There is some of the advocates working on the issues are, in addition to health and disability advocates, where I am from, Shriver National Center on Poverty Law. There are advocates such as Health and Medicine Policy Research Group, the Campaign for Better Health Care, Age Options, which is an area agency on aging. There are many groups working on these issues that have coalesced around the hearings as well as other coordinated efforts. IllinoisHealthMatters.org is a website that we have all coordinated together on. And if you go to IllinoisHealthMatters.org, there is more information on each of these efforts, as well as a list of many agencies that are working with them, including agencies that deal with specific, like limited English-speaking populations and other mental health organizations, National Association for Mental Illness, Catholic Charities, Lutheran Social Services, the Jewish Federation, Metropolitan Family Services, Heartland Alliance, and many provider agencies, as well as other advocacy organizations. And now I will turn it over to Andrea, and I believe we're opening it up for questions.
Yes, so thank you so much, Stephanie and Alexander, for your presentations. And we are going to take questions now. We have deliberately allocated a lot of time because we knew that you all would have a lot of questions. And John Bowman is going to go ahead and ask the first question and give it an answer.
I've got actually a couple questions here, Andrea. One person writes, what about the federal lawsuits we hear about? Isn't the law just going to get thrown out by the courts as unconstitutional? The answer to that is that the lawsuits involve one provision of the law, the individual mandate. The individual mandate is part of the strategy with the private insurance part of the Affordable Care Act. It's the way that the strategy the law used to make sure that healthy people participate in the, in the healthcare pools that will be offered through the exchange, which keeps the cost down for everyone else. And so they said to get healthy people to participate, we want to make sure, we want to give them an incentive. So if they don't participate, we're going to charge them with a penalty that'll help to pay for things. The lawsuits are trying to overturn that as unconstitutional. The courts have split pretty evenly on it, and even some conservative judges on the federal courts of appeals have ruled in favor, have upheld the mandate. It looks like it'll go to the Supreme Court probably next year, so there'll be a decision next year. I think the odds of the individual mandate surviving in the Supreme Court are 50-50-ish. But even if it is struck down, that is one part of one title of 9 titles of the Affordable Care Act. So most of this law is going forward, regardless of what happens in court, and is already going forward. And even if the individual mandate is struck down, there are other strategies to get healthy people to participate in the exchanges. So even the formula for making the exchanges affordable would not be completely upset. So the federal lawsuits are important. It's worth keeping an eye on it, but it's not about the entire health care reform law. Another question we have here involves asking Stephanie and Dr. Brown, care coordination, sometimes that the questioner asks, if that's like an HMO type thing, what are the pluses and minuses of care coordination? What's the upside of that, and what's the potential downside that we should be watching for with respect to people who have mental health issues?
Well, there are several possible advantages from moving from straight Medicaid into a managed care. You may have access to a wider network of providers. If you have straight Medicaid today, it's often extremely difficult to find a provider who's willing to accept it. So you may get access to a broader network, and you may get access to a better network as well. With coordination comes the possibility of enhanced services, prevention services, transportation services, but there's also the threat of limitation of services as well. Although even with straight Medicaid in certain instances, the state is already moving toward limiting certain services. So it's really hard to tell what it's going to look like long term. Aetna and AlignCare have been pretty open in saying that this is new for them, although they both have experience in the area, and their first priority is going to be the medical issues of these clients, because there are huge expenses incurred on the medical side, and they won't really be focusing on behavioral health until they get a better handle on the medical side. Do you want to add anything, Stephanie?
No, I think that pretty much covers it, except that to let people know if they're providers and they have clients, or if they're clients or consumer groups, there are advocates who can work with your clients or yourself individually to help with your individual situation. So health and disability advocates, the Legal Assistance Foundation of Metropolitan Chicago, and other organizations can actually work with an individual and look at their providers, their medications, the services that they've been prescribed by their doctor or psychiatrist or psychologist, and negotiate or work with the insurance company like Aetna or AlignCare to make sure that you're getting what you need. Not that it's always successful, but that individual advocacy can sometimes be necessary and actually help get you what you need.
Other advocacy organizations involved in keeping an eye on the integrated care pilot include Prairie State Legal Services, which offers legal assistance to low-income people, AIDS Legal Counsel in Chicago that helps people in the suburbs who have AIDS, HIV-related issues around the integrated care pilot. And on a sort of broader policy level, the AIDS Foundation of Chicago, Illinois Maternal and Child Health Coalition, Illinois Public Interest Research Group, and many, many others that you can find on IllinoisHealthMatters.org.
Let me add one more thing about the managed care. From the provider side, there was a lot of hope that Aetna and AlignCare would be able to provide streamlined billing in ways that Medicaid doesn't, and so far that has not borne out. The providers are really struggling with billing. Aetna and a line of care. Long term, we expect that it's going to be better to be billing Aetna and a line of care than Medicaid, that the problems will be fewer. And as a provider, you also have issues of getting pre-approvals for certain services that you didn't have for Medicaid. And again, short term, that's causing a lot of burden on the providers. Long term, we're all hoping that it's going to become easier.
Thank you, Alex. Two other questions we received. One is just if we could repeat what we were referring to with the $11,000 per year. So $11,000 per year is a rough estimate of the actual maximum amount of money that a person could have and be eligible for the new adult group Medicaid after 2014. So that's approximately 138% of the federal poverty level. The federal poverty level is actually set by the federal government every year, and it rises just a little bit each year. So it's always a little bit specific, but it's around $11,000 a year at this point. Above $11,000 a year, there are going to be options for health care. It's just that below $11,000 a year, a person will most probably be eligible for Medicaid. Above $11,000 per year, if they meet other requirements, they will most likely be eligible to purchase insurance through the health insurance exchange. And at the lower income levels, $12,000, $15,000, $20,000 a year, they or their family will have a premium subsidy that will help them afford to buy that insurance. One of the other questions we received is if we could describe more about health homes, and the question is, are there some good models out there that include mental health services? Health homes are very new, but they're based on an old concept, which is coordinated care. They are, there are only a few states so far that since the federal government described health homes as an option to the state 6 months ago, there are only a few states who have applied to have health home systems, and Illinois has not yet applied, so we don't actually have an example here in Illinois. But there are providers who already operate coordinated care systems with behavioral health as a component or a central component to that are very much like health homes and kind of on the way there. One of them is Heartland Health Outreach, which provides a federally qualified primary health care center that serves a homeless population, and they also provide behavioral and mental health and substance abuse treatment services, and they also coordinate through case management and social work those services for that population. They are similar in design to a health home, as is programs run by, for instance, the AIDS Foundation of Chicago, where they're coordinating primary and behavioral health care for a targeted vulnerable population, such as people with mental illness. What is not included in those two arrangements at this time is specialty care and hospital care. So that's what would make it new.
We got a couple of tough questions with people asking questions that cut right to the heart of important issues here. One is, how will you get broader participation by providers with Medicaid rates so low and projected to decrease with future cost containment? The main answer is that we all have to pay attention and do advocacy on it. There are other strategies, but that's something that's hanging fire. The department has ways to leverage some providers to participate, but by and large, doctors are free to participate or not participate. And so the rates and the speed of payment and the reduction of overall hassle with dealing with Medicaid are a part of this larger picture. Now, doctors and hospitals and clinics and other providers will be forming these care coordination networks to serve the private insurance and Medicare populations that pay more than Medicaid. And so one of the strategies there would be to link to Medicaid, to get people in those coordinated care networks to also accept Medicaid. And then, as I said at the beginning, it's important for everyone to pay close attention to this and advocate with the state not to cut provider rates and to improve reimbursement hassle and speed. You guys want to add anything to that?
I think it's going to be a particularly difficult challenge, and it's going to require both a carrot and a stick and a lot of advocacy to do it. There are a lot of mental health and social service providers, agencies out there today that are looking at their current client population and paying close attention to how many of them are going to be eligible for Medicaid. So they may not be billing Medicaid very much right now, or may not be billing it at all right now, but moving forward, this is already the population that we're serving. They're going to have Medicaid. How can we be a bigger provider or a better provider? But those are pretty much limited to behavioral health services.
And the only thing I would add is, in addition to that, a lot of providers, such as Metropolitan Family Services and others, are also looking to how they can be a part of the enrollment process moving forward. Enrolling 700,000 people into just Medicaid in January 1st of 2014 is going to have to start way before then. And we believe, on behalf of people who are traditional providers, safety net providers and organizations, that we know our populations and our clients best. And the federal government has said as much in regulations that they've put out, that there need to be navigators that will help people enroll in the new Medicaid and health insurance exchange and enroll in some of these coordinated care arrangements. And the providers and the agencies and organizations who've traditionally worked with these populations need to be involved in order to help people who are our most vulnerable citizens, homeless, severely mentally ill, limited English speaking, more marginalized populations that may need to be found as opposed to them finding us. So we really need to coordinate together, and that's one way you can get involved, is to, as a provider and agency, start getting ready, as Dr. Brown mentioned, figuring out who among your current populations will need to get enrolled into the new benefits, and maybe even what we can do now to increase their enrollment in Medicaid.
Here's another astute question. The listener asks, will any current Medicaid coverage be reduced or eliminated with the new laws? The answer is that the coverage package of Medicaid itself, as it exists now, is not changed by the new law. However, for the expansion population, this new group of eligible people, the Medicaid will have to at least cover the essential benefits package that Alexander Brown talked about in an earlier slide. But that coverage, while it's very good coverage, is not as comprehensive as Medicaid. What Medicaid covers is everything medically necessary. At least theoretically, that's what it covers. There are states have some optional services that they could withdraw, but that's current law. So the new law doesn't change any of that, and all the people who are already eligible for Medicaid will get the same coverage package. There is an issue, though, and an area for advocacy to make the coverage package for the newly eligible Medicaid group as comprehensive as possible, more so than the essential benefits package and more like the current Medicaid package. You should also be aware that in the Affordable Care Act is a provision called the Maintenance of Effort Requirement. The states that participate in Medicaid, which is every state, is required by the law not to cut services, not to cut eligibility, and to not impose harsher eligibility requirements, like the amount of times you need to come in and recertify your eligibility and things like that. So that will lock into place between now and 2014 the eligibility levels and services provided under Medicaid. It does not cover, getting back to the prior question, it does not cover provider rates, which is why provider rates are at least out there being, they are allowed to be considered for cuts. It's our job to make sure they're not cut.
And I would just like to add that some people have asked us, well, why did Illinois, or how was Illinois able to cut programs such as All Kids and Illinois Cares RX if the maintenance of effort provision says that the state can't cut Medicaid? The answer to that is that our All Kids program was a combined program of Medicaid and a state private insurance program, and last year the legislature voted and passed a statute that reduced the eligibility or cut part of our All Kids program, but not the Medicaid part. So as of July 1st, 2011, no new children who had family incomes, if their whole family income was over 300% of poverty, were able to enroll in All Kids. Children who were over that income level but currently on All Kids were grandfathered in for 1 year until July 1st, 2012. Approximately 4,000 children are on this grandfathered in program, and in July 1st, 2012, unless there's any change to the law, they will lose coverage. Some of those children do have pre-existing conditions and their families are at higher income levels, but are not able to purchase insurance for them because the parents either are not employed, or they're employed and their employer doesn't offer insurance, or the insurance that their employer offers is not affordable to them. And some of those children have pre-existing conditions that are related to mental health coverage. And we as advocates are working, the Shriver National Center on Poverty Law, Illinois Maternal and Child Health Coalition, and Health and Disability Advocates to advocate on behalf of these children to see if there are other options for them to be covered by July 1st, 2012, and if not, to help enroll them into any available coverage that exists for them.
One question here, how will the Illinois Department of Human Services deal with the increased burden of enrollment? Well, let me start with a lawyerly technicality. The agency that will implement the expansion of Medicaid and the, to some extent, the relation of Medicaid to the healthcare exchange for private insurance, that agency is the Illinois Department of Health Care and Family Services. Now, the Department of Human Services, though, administers the state's mental health programs. And one of the main changes that's going to happen there is that a lot of the people being served by those programs who are currently uninsured, and therefore, if they're served at all, they're served either by the private fundraising of those organizations or by grants from the state, they will be eligible for Medicaid reimbursement. So that will help expand the capacity of the field to deal with patients because there'll be a reimbursement mechanism, and there won't be, there'll be many, many, many fewer people without insurance. But it will create a healthcare sort of manpower workforce shortage, which is already acute in the mental health field. There aren't enough psychiatrists and counselors. And so now the Affordable Care Act has some pots of money for loan forgiveness and for the building of the healthcare workforce in advance of this expansion. And so those strategies are among the ways that will at least attempt to deal with the increased enrollment. Anybody want to add to that?
Yeah, as was referenced earlier, I think it's going to be a huge challenge. The state departments charged with processing all these applications are already incredibly overwhelmed. If you've helped someone apply for Medicaid today, it's a real challenge. So they are going to have an extremely hard time getting the applications done earlier with the assistance of social service organizations is going to be helpful. And the providers, the social service organizations are going to be inundated with even more clients that are now eligible for the services, and the reimbursements are probably not going to be covering services any better than they are today or much better, and there'll be a backlog, even more than today, waiting lists.
Oh.
Thank you. Another question that we received is after health care reform, after January 1st, 2014, will pregnant women and children with income over 133% still be eligible for Medicaid, or will they have to buy on the exchange? This is a little complicated because the law says a few different things for pregnant women and for parents and for children. So a state can continue to cover pregnant women under Medicaid, I believe, up to 200% of poverty. That is actually technically covered under the SCHIP program, which is the State Children's Health Insurance Program, which is a Medicaid-like program. Children can still be covered under the same program, the SCHIP program, the State Children's Health Insurance Program. We call in Illinois the whole thing All Kids, but it's in there up until 2019 at this point, if I'm correct, when SCHIP sunsets. So the answer is yes, children and pregnant women up to 200% of poverty will still be covered in a Medicaid-like program. In Illinois, it's exactly the same, called SCHIP, or All Kids and Moms and Babies is what we call it, until at least 2019. Then they can be transitioned onto the healthcare exchange. There is also a third option, and a lot of these things, as you can tell, are not completely decided yet, that the state could take called the Basic Health Program, where families could be covered under a Medicaid-like benefit all in one package. It is confusing because, as in all Medicaid programs, the federal government gives states certain options. And so the statute, we should have mentioned at the beginning, is sort of one set of rules. The federal government is now setting out hundreds of pages of proposed rules that the states are going back and forth and answering. And so some of these decisions are still being decided. So in each state, as they set up these systems, we'll have more and more information. And IllinoisHealthMatters.org is a great place to get the up-to-date information on what Illinois is choosing to do in any given moment. And with that, that is the last question, and I will turn it back to Andrea.
Thank you so much, Stephanie, John, and Alexander. Those were wonderful questions and answers. Thank you to all of the people who submitted questions as well. We are going to wrap it up here. And again, all presentations and some additional resources are actually going to be posted on our resources webpage. We put the link to that on the screen that you should be seeing. And you'll also receive an email with the link to that resource page. Stay tuned for an email inviting you to register for the next webinar in this Illinois Health Matters series of webinars on implementation of the Affordable Care Act in Illinois. So thank you again for attending today's webinar. Please complete a very short survey at the end of this webinar and subscribe to Illinois Health Matters for the latest developments in health reform in Illinois. If you have any questions, please contact me at the email address shown on the screen. Thank you.